Kia ora koutou, good afternoon everybody. It's a great privilege to come to us. Isn't it great to have a free CME training day? So thanks so much to Sue and the team. We're going to quickly cover off 3 diseases in a few minutes, but one of them is particularly timely because, as you'll know, there's pertussis around. We're at the beginning, most probably, of a whooping cough outbreak. And so just to be a bit of a reminder about what that involves is really important. Other countries have seen this. We're a little bit behind. UK and Australia particularly. You can see the figures for down the bottom there, Queensland, Victoria, New South Wales have had massive numbers of cases of pertussis this year. And we expect this. This happens cyclically. There was an outbreak in 2012 to 13 and 2017-18. So it's not unexpected as immunity wanes, we'll see the increase in cases of whooping cough. So we have a focus. This isn't like measles where we try and stamp out the disease. The aim is very much to protect the most vulnerable, particularly those under 1. And what we do know is it's unfair, like most diseases. It particularly impacts young Māori and Pacific Pepe. And you can see those figures that you just extracted from this year on the right. When the total number of cases by ethnicity, you can see how high the case numbers are amongst Māori and Pacific, with really disproportionate, particularly in those under 1s, which is so key. You'll see those figures from IMAC and the immunisation handbook. It's pretty frightening. Around half the babies with pertussis under 1 end up in hospital, of which about 1% will die. And you'll have read in the paper last year there were cases of malignant pertussis where children did die. In the 2019 measles outbreak, no children did die in New Zealand, but they have died of whooping cough. It's incredibly serious. And yet we have a great tool with vaccination. And of course, that's changed a bit. And this is you don't need this reminder, but be opportunistic with this wherever you can. And that second, if you're seeing a hapu mama with a family member, just inquire, have you had your boostrix? It may be that you are the opportunity to give that in the 2nd or 3rd trimester. Encourage that cocooning. It's not as effective. The most effective things are the maternal boostrix and on time, every time infant vaccine at 6 week, 3 month and 5 months. But that cocooning does help as well. All those strategies, and unfortunately it's hard. Everyone knows that primary care is under the pump, but you may see opportunities to do that opportunistically. Testing. Now, I know this has changed a wee bit and you get different advice as time goes on. Currently, we're in a phase where do test for pertussis. If you're thinking this could be pertussis, do a PCR nasopharyngeal swab. I know they're unpleasant. Serology does not have really a place, and that's really important. The swabbing is what counts. So if it's characteristic hoop, do a swab. URTI that's prolonged with an ongoing cough, do a swab. Post-tussive vomiting, more common in adults, do a swab. However, consider the timing of that. Don't do it if the person's been coughing for 3 weeks. And if you're uncertain, like, I think this could be pertussis, one of the most important things you can do in that case is actually, I'm going to jump a slide, 3. Ask if anybody else in the house is sick, because you might find that somebody has had symptoms, and then you say, well, actually, yeah, a few of the others have started coughing, swab them, and then you've got the diagnosis in hindsight for the others. In the outbreak, we've seen about 80% of households also get it. So despite vaccination, if you had a household of 10, you'd expect currently 8 of those people to get pertussis. So do inquire always if others have symptoms. What we need to do is swab, at least get 2 positive swabs, and then presume anybody else with symptoms is also pertussis positive. We jumped a couple of slides, but basically it said if you're thinking pertussis, please notify us. Even on suspicion, it is kind of what is recommended in all the guidelines. So if you're doing a swab for pertussis, notify us either through an e-notification, they've only come online for pertussis this year, give us a call, or use the email thing to notify at adhb.govt.nz. If you're thinking about the family, you're also doing good personal health care as well as great public health care. So you might get letters from us about the high-risk contacts, and I apologise that this is hard when you're already pressed and you're getting letters to see people relatively urgently for treatment. Why is it? It's because we know that, again, protecting those under 1s can save lives and keep children out of hospital. So when we are aware of someone who attends perhaps a daycare or a school, we actually do this contact management, really a risk assessment to see who would benefit. Information is important, but also a number who need to really get onto the antibiotic of choice for that. Now, the under ones are particularly targeted. Hapamama in the last trimester particularly. We struggle a bit more with the immune suppression, but we actually send letters. So you might focus on the whānau and the family, but if you may get letters of other people at risk from us. Again, there is no specific targeted funding for that at this time. So it is complicated. I expect most of you will see that in the weeks and months to come. It's coming, and it could be pretty bad because, as you know, our immunisation coverage is so much lower than it was a few years ago. Briefly to mumps, and when I sort of started thinking about this, we were seeing quite a few cases of mumps. They're mostly sporadic. We're not in an outbreak setting at all, which is fortunate. That was a possibility. About half of the cases we've seen in Tamaki this year have been people who've come in from overseas. And because it's got a long incubation period, sometimes they've been back in the country a couple of weeks. So always inquire if you're seeing someone with paratitis, have you travelled in the last few weeks? You'll know, and we'll cover the countries in a second, but many countries do not vaccinate with an MMR. They vaccinate with an MR, measles and rubella, but don't. So many people do not have that mumps protection. You'll see in those, just looking from January of last year, many of our cases have been in the 20s to 40s age group particularly. And you see the countries where they have come in from, with India contributing more than anywhere. So again, if you're seeing someone, just inquire about travel particularly, and remembering that mumps doesn't always have the classic hallmarks. You may not have much of the constitutional symptoms. It may be just a paratitis. It doesn't necessarily have the fever at all. So as I said, it can be quite non-specific. Not only have they travelled, but has somebody else they know travelled. We've been very fortunate that the cases have been sporadic and we haven't seen very much spread from person to person at all. Managing mumps is complicated because of that long incubation period. It means the time of relative isolation or staying from others is particularly long and challenging. And so, of course, the best tool in the box is vaccination, but it's not as effective, the MMR, as it is for measles. We know that for 2 shots, it's 99% for measles, but really looking at up to 83 to 88% effectiveness when it comes to mumps. But still incredibly important. And there's those countries I mentioned lower down, many Pacific Island countries. Now, even if they've introduced it in the last few years, the great majority of the population will not have that mumps protection. And then people who travel in from many other, particularly Asian countries, and I alluded to India before. The test here also a PCR, but unlike the nasopharyngeal of pertussis, the buccal swab, sort of a flock swab around the upper rear molars is the test. Try and avoid the blood tests. They mostly confuse things. And often if you have ordered a serology test, our team will often give you a call back and say, look, you're still within the time period where it's suitable for a swab. Would you mind doing the swab? I know it's annoying, but that is the best test by far. It's the only one we can really diagnose well. If you have got an IgG from before they were infectious, we could count that as a sign of immunity, but even a positive IgG when someone has the illness, it could be either because they're immune or already the IgG is going up as a result of the illness. So you can test up to day 9 from the paratitis onset. So it is really important to calculate and inquire, when do you think the swelling started? So IgM not recommended generally. So what should you do? Again, notify us if you can. If you've taken a swab, if you're considering mumps, we love to be notified on suspicion rather than just waiting for what we call the direct lab notification. The lab is very, very good at always letting us know about positive tests, but we can start the mahi if we're already aware that you're considering mumps or pertussis, as I said before. So advise them until you've got their swab, stay away from daycare, education settings. You're reducing the chance of extra contacts if they've stayed at home pending that buccal swab result. And then we'll look after it. Once the swab is positive, we will determine whether what the person requires. That'll depend on their risk assessment. Do they attend school, daycare, healthcare worker? So we will work out any particular isolation or restrictions that apply. I said this already, the IgG is really not to be considered except as a measure of immunity beforehand. And that most people don't have that on file. You might have a measles serology, or you're probably more likely to have a rubella serology, but unlike your mumps. In theory, we could order it on a tube that's sitting in the lab, but we try not to do that. Notify on suspicion, and do use those e-notifications. Have many of you seen the e-notifications sitting on the PMS for public health? Measles has been there like 2 years, but the others have come online recently. So hopefully you don't have to notify as much, but it saves you time because you're not having to pre-populate all the fields, which is really, really helpful. I was asked to have a quick word on syphilis. Now, syphilis is a notifiable disease, but interestingly, there's a few, particularly the sexual health diseases, although they are notifiable, our department, the Public Health Service, doesn't manage them particularly. However, really word of note that syphilis has, although there was a minor dip in the times of COVID, it is on the increase again and probably back to similar levels beforehand. The case distribution has changed somewhat. We can see about 60% of cases are in men who have sex with men, but that's 60%. There's 40% who that does not apply for. Heterosexual males, heterosexual females, and others. And you can see what particularly, although syphilis itself is serious, the aim is to reduce congenital syphilis, which every case is an absolute tragedy. And most years you can see there's been between about 3 and 7 or 8 cases per year, which is tragic, almost exclusively Māori and Pacific cases. So what is the word here? Test. Be opportunistic again, because that could make all of the difference. And this is just from health pathways like most of the talks I know have referred to today. If there's an increased risk of an STI, test. If there's symptoms, of course, test. If they've had sexual contact with a case of syphilis, of course, test. Immigration, Karen's mentioned this particularly from a refugee scene, and particularly in pregnancy. And you'll know that the guidelines have changed in pregnancy rather than in booking to routinely here, certainly in Tamaki and many other parts of the motu, in the 3rd trimester. But there may be other times as well. The aim must be to eliminate congenital syphilis. And it's really hard if, of course, women present at the time of delivery without antenatal care. So we have to, I try encourage, and again, it may be opportunistic. You may have that one chance when you consult with someone's family to arrange that syphilis screening. Because just as was mentioned earlier, some people do not know what their partner has been up to and therefore may not think they're at any risk whatsoever of syphilis. So seek advice if you do come across syphilis again, and I found this, I also had the privilege in a previous few years of working where Karen does at the Refugee Centre. And it was so useful to always draw on the experience of the Auckland Sexual Health Service. I'm sure many of you have done that. Don't manage syphilis on your own. Seek the help of others. So that's a very quick race through, but I'm sure you will see syphilis. Consider mumps. And you will see pertussis. You may see mumps, and always consider syphilis. Kia ora, thank you.